So today we're going to be talking about non-paretic diplopia, and that is a very counterintuitive subject because basically you have double vision, but you don't have any weakness of any muscle or nerve. It's a non-paretic, no weakness diplopia. The prototype for non-paretic diplopia is patients who don't have overlapping field, and the classic example is patients who have a pituitary tumor who have a bitemporal hemianopsia. So in a patient who has a bitemporal hemianopsia, what they really have is juxtaposed nasal field juxtaposed to one another, and the nasal field of one eye overlaps with the temporal field of the other eye. So when you have a bitemporal hemianopsia, you actually don't have any overlapping field because your temporal field has been lost. And so when you have this juxtaposed nasal fields, they can slide on one another and cause a hypertropia. So the nasal fields can slide, or they can separate or overlap if you have an esotropia or an exotropia. So patients with a pre-existing phoria can break their fusion if they have a non-paretic diplopia. The other forms of non-paretic diplopia that you should be thinking about are when you have a subretinal neovascular membrane or an epiretinal membrane. So as you know, in your eye, your fovea is the center part of your vision, and so conditions which move this fovea, either like an epiretinal membrane or a subretinal neovascular membrane, then the fovea are not aligned, and so the central vision is not aligned with the peripheral vision. So there's nothing wrong with the nerves or the muscles or the junction. It's a central versus peripheral rivalry. And so when you have a rivalry between the fusion of your peripheral field and your fovea, because one fovea is displaced, that patient has a non-paretic form of diplopia as well. There's no weakness, it's just the two eyes are not aligned on the target. And so we can tell that by looking at the patient looking straight ahead and seeing whether the diplopia is the same with the lights on or the lights off. With the lights off, you've taken away the peripheral vision, and so they're relying only on the central vision. And so patients with central versus peripheral rivalry really can only choose to fuse one or the other. Another type of non-paretic diplopia is when you have supranuclear palsies. So supranuclear palsies can disrupt your fusion. So there's nothing paretic or weak around your muscles. It's just you can't make the two images to come together. And one of the classics causes of fusional deficits at near is convergence insufficiency. So as you get older, or if you're sick for any reason, you're not able to converge, and that will cause the eye to drift out, exotropia. And so convergence insufficiency is a fusional problem at near, and that's a super common cause of diplopia at near. But there are other things that can disrupt your fusion. Anything that makes you sick or disrupts the fusion can cause the image to split. So if the two images are not the same in any way, then you won't be able to fuse them. So if one image is smaller or one image is bigger, micropsia or macropsia, you won't be able to fuse that. If the two images aren't overlapping, like in the hemifield slide phenomenon, or if you can't fuse the central versus peripheral because they're not in the same location. Those all will cause fusional problems. In addition, torsion, so if the image is tilted, it's going to be hard to fuse a tilted image on top of a straight image. So the torsion alone might be the barrier to fusion. And finally, some patients simply have lost the supranuclear control of fusion. And that is called horror fusionis. So when you can't fuse, even with the prism, even with your eyes aligned, that is horror fusionis. And it's like horror, like a horror movie. And fusionis, you cannot fuse. So if you just know these non-paretic forms of diplopia, the hemifield slide phenomenon, retinal etiologies that move the fovea, central versus peripheral rivalry, supranuclear fusional abnormalities, and the horror of horror fusionis, you know the non-paretic forms of diplopia.